Hi, I'm Andrew Cole. I'm Director of the Epilepsy Service at Mass General and Chief of the Division of Clinical Neurophysiology. And I also am the Program Director for our Epilepsy Fellowship Program. I work on our fellowship programs in conjunction with Dr. Doug Moss, my colleague, who's the Program Director for the Clinical Neurophysiology year. And we actually work together to manage both fellowship programs. And I thought it would be helpful if I told you just a little bit about our fellowship as you're considering your applications. Let me tell you about our program. Our program is ACGME accredited for those for whom that's important. And we typically have a 2-year epilepsy clinical neurophysiology fellowship. There are individuals who come to us with the idea of doing just 1 year of fellowship, and that may be either in clinical neurophysiology or in epilepsy, depending on the goal of the individual. The goal of our fellowships is to develop people who are in a position to direct and run an epilepsy program or a clinical neurophysiology laboratory focused on EEG when they leave the fellowship. During the course of our fellowship, we have a somewhat unique opportunity where both adults and children are treated at this hospital, and our fellows see patients either in the laboratory or in the clinic from all age groups. The exposure to pediatrics is relatively unique among many adult-based clinical neurophysiology fellowships. You're also exposed to a broad variety of epilepsy treatments, to medication, to epilepsy surgery, of course, to neurostimulation, to laser ablation, to dietary therapy, especially in the pediatric universe. Our program is sort of structured around rotation, and essentially the major components are the routine EEG laboratory. Our routine EEG laboratory does about 4,500 studies a year. About 20% or so of those are pediatric studies. And when one is assigned to the EEG lab, it's your job to read all of those EEGs during the course of your rotation and then review them typically the next day with the attending who will sign them out. The epilepsy monitoring unit is another major rotation. That's where we admit patients for either diagnostic studies or pre-surgical studies. Our epilepsy monitoring unit is heavily weighted toward the pre-surgical population, although we do have our share of diagnostic cases as well. The epilepsy monitoring unit is divided into an adult and a pediatric unit. The pediatric unit is geographically up on one of the pediatric wards, so it's remote physically, although in the same building, from the adult unit. The adult unit is in the Lunder Tower, which is a state-of-the-art facility that opened in 2012, and where the control room for our epilepsy monitoring unit sits. The fellow's responsibility in the monitoring unit is to oversee the investigation and recordings of patients who are admitted to that unit, both children and adults. And that's a broad job. The patients are actually managed on the clinical neurology service by neurology residents. The monitoring unit is staffed by an adult epileptologist for the adult patients and by one of our pediatric epileptologists who cover their own pediatric patients. An increasing population of patients in our monitoring unit have invasive recording electrodes in place, and those studies, of course, are complex and require some effort to come to terms with, but the exposure to intracranial recording now is quite rich in our program and is a significant component of the EMU experience. A third rotation is what we call the LTM service. This is a service that provides continuous video EEG monitoring elsewhere in the hospital, mainly in intensive care units, about 40% of the time in the neurological intensive care unit. Those studies are widely used now across neurology in academic medical centers and deal with issues such as status epilepticus, coma, subarachnoid hemorrhage, severe encephalopathies, and differentiating sometimes between those conditions. A fourth component of the program is elective time, and fellows may choose to do elective time in a variety of disciplines, including sleep medicine, intraoperative monitoring, perhaps research laboratory work, maybe in imaging or neurosurgery or even neuropsychology if those things are of interest to a particular individual. We have a weekly clinic. We meet on Friday mornings. The entire adult epilepsy service is present in the clinic at that time. We typically see 55 to 75 patients a week as a group. Fellows have their own patients. They're responsible for their management. They see those patients longitudinally, but they staff each case with one or another of the attendings available in the clinic that day. This allows a degree of autonomy, a substantial degree of autonomy, but also reasonable backup. From a didactic and conference point of view, we have a rich menu of opportunities for our fellows. Mondays, we have an EEG conference where we review problematic EEGs as a group, challenge each other's opinions, and learn from each other in doing so. We then go to our epilepsy surgery conference where typically 1 or 2 cases a week are discussed in deep detail, reviewing all the data and generating surgical hypotheses and then a surgical plan. Our fellows take an important role in that clinic in presenting the patients that they monitored, in creating a clinic note that summarizes the findings of that discussion, but most importantly, in formulating an opinion and articulating it in the course of the conference. We have a post-clinic conference immediately after the clinic, where often we'll have some lunch. But the main thing we do is review all of the cases that were seen by the fellows that day. So we go through each list. If the case is simple and straightforward, it's a short discussion. If the case is more complicated, there's a longer discussion. We can pull up images, we can look at EEGs, we hear opinions from all the fellows and all the faculty in a place that really is dynamic and allows a real exploration of the subtleties and the nuances of those cases. There are research opportunities in our program as well. It's a busy clinical program, but there is time for research and there is time for writing. Some of our fellows in the past have written as many as 8 or 9 papers during the course of their fellowship. A lot of that is dependent on the energy and motivation of the fellow, but the opportunities are abundant. There are opportunities to participate in clinical trials, to study ICU EEG, to do machine learning aided quantitative analysis of EEG and classification and event recognition paradigms with some of our senior faculty, to focus on the interaction between epilepsy and dementia with Dr. Alice Lamb. The biggest part of our program that I want to tell you about is sort of the culture. And Mass General is an extraordinary place. We're lucky to have incredible resources. And I think this is a hospital where collegiality is truly valued. The hierarchy does not determine the nature of all relationships here. Patient care is, of course, first and foremost, and I think that's a fine aligning principle for us as we think about our day-to-day work and decision-making. The single hospital experience allows one to absorb many different perspectives from the faculty, but a relatively unified programmatic approach to epilepsy. The fact that we have children and adults in the hospital allows that broadening of the exposure as well. We hope you'll have an interest in our program. We look forward to meeting you. Please let us know if we can answer any questions. And if you're interested in applying, there's a website below, www.seizure.org. Thanks very much for your time and attention. Bye-bye.